Well, good morning. I think we'll get started as people still trickle in. It's great to see that the audience is growing by the minute. First of all, welcome. I'm Davide Manicero, the Chief Medical Officer for Infectious Disease at QIAGEN. Newly rejoined the company literally 8 weeks ago, and delighted to be chairing what is one of my first meetings presenting on syndromic diagnostic. I must say that today I'm just one of the spectators. And often as QIAGEN, we feel that when we are facing the audience on talks on syndromic diagnostic, we are just part of this big learning curve on syndromic diagnosis. We keep learning, and the learning comes from this side of the room. And the reason we are learning is because we are entering uncharted territory, and I'm proud to say that QIAGEN is moving forward in this uncharted territory and setting up some coordinates. It's uncharted territory for laboratories, but particularly for clinicians, like I used to be, I should say. And I'm not at all, despite the gray hair, but I come from a generation where diagnosis was taught as a guessing process with differential diagnosis and a rule-out, a rule-in approach. Syndromic diagnosis is changing that. And as QIAGEN, as much effort as we can put in delivering a high-quality product, at the end of the day, the impact is coming from the way you're going to utilize syndromic diagnostic and the way that as molecular pathologists, as laboratories interact in the interface with physicians. And I think as QIAGEN, what we are committed is delivering on the three key parameters for syndromic diagnostic, and that is delivering through QIAstat, a platform that can deliver speed, comprehensiveness through the multiplexing that we can offer through our panel, but most importantly, and I think uniquely to QIAstat, is offering that additional insight, for example, through CT value or amplification curve, that the laboratories can utilize to improve clinical utility and provide, ultimately, the information that is needed to impact on patient lives and outcomes. I'm delighted that we have two speakers who have eagerly accepted to be with us today and will be presenting two different experiences and first-hand experience on utilizing QIAstat. Let me introduce first speaker is Dr. Utsav Pandey. He's a postdoctoral fellow in clinical microbiology at the Department of Pathology and Laboratory Medicine at the Children's Hospital in LA. He has a keen interest on syndromic diagnosis, seen from the laboratory side, has done quite a lot of research and clinical work in syndromic meningitis, pneumonia, and upper respiratory tract infection. And be presenting with us today his early experience utilizing the QIAstat respiratory panel. So I'm glad to introduce Utsav, who will be taking us through a small journey in the next 20 minutes. Thank you.
Morning, everyone. Thank you, David, for the introduction. So as David mentioned, I'm a clinical microbiology fellow at Children's Hospital Los Angeles, and I'll be sharing some of our initial data utilizing the QIAstat-Dx respiratory panel. So here's a brief outline of my talk. I'll start off talking about upper respiratory infections in children, what the common pathogens are, what are some of the challenges with diagnoses of these infections. Then I'll talk a little bit about syndromic testing and how it can have a clinical impact on management of these upper respiratory tract infection. Transition to talking about the QIAstat-Dx respiratory panel and my personal experience using the panel, and I'll finish up by talking about short comparison that we did to to the BioFire film array respiratory panel, which is the current standard of care at our institution. So as most of us are aware, upper respiratory infections are very common in children. For children under the age of 5, they experience a mean of, on average, about 6 episodes of upper respiratory tract infections every year. Obviously, that puts a lot of burden on the healthcare industry. It accounts for about 43 million physician visits every year and costs healthcare industry about $40 billion annually. And in most cases, these infections are uncomplicated, but these infections have the potential to be complicated by bacterial infections such as sinusitis, which is the infection of sinuses, otitis media, which is an infection of the middle ear, and pneumonia, which is more of a lower respiratory tract infection. So I just wanted to talk briefly about this paper that was published in the New England Journal of Medicine in 2015. And this paper looked at the incidence of upper respiratory tract infection in children between the age of 0 to 17, so newborn to 17 years old. So they looked at a total of 2,222 patients. So the main message here is that almost 65% of the pathogens that caused upper respiratory tract infections in these children were viral. And if you further break this group down by age, then you see that the proportions change slightly, but viruses do remain as one of the most common causes of upper respiratory tract infection. This is another figure from the same paper, and this figure breaks down the most common pathogens that we usually see that cause upper respiratory tract infections and its incidence by age. So as you can see, for children under the age of 2, RSV and rhinovirus are the two most common pathogens, but with age, these proportions change slightly. And for example, something like mycoplasma, which has very low incidence in children under the age of 2, increases in incidence as children age. So one of the main challenges with management of upper respiratory tract infections is the use of antibiotics. So when etiology of these upper respiratory tract infections are not known, antibiotics are often prescribed. And as we all know, overutilization of these antibiotics contributes to antimicrobial resistance. So the knowledge of the etiology of these upper respiratory tract infections is essential to facilitate management of the disease and for antimicrobial stewardship. And what's also important is the duration of the time from collection of the specimen to results. So the turnaround time of assay is associated with decreased empiric antibiotic use, less exposure to x-rays, and shorter length of stay in a healthcare facility in general. So I just wanted to share some data from our institution regarding some of the most common respiratory pathogens. So on the x-axis here, you have weeks of the year. So it goes from week 35 to week 34. So that's from October to October of the next year. And this is just for flu A between 2016 to 2019, just for our institution. And on the y-axis, you have incidence. So as you can see, during the winter months, starting in about November, so right about now, the incidence increases, and then it goes up, and then it kind of dies down towards the beginning of spring. So we see a similar trend for flu B, which is a lot less common than flu A, except for this 1 year in 2017-2018, where we saw a large spike in number of flu B positives. and similar trend for RSV, where we see a spike during the winter months. But these are some of the viruses that we track, but obviously these are not the only ones that cause infections. Enterovirus, rhinovirus, they can cause infections during summer months. Adenoviruses can cause respiratory infections throughout the year. So how does syndromic testing help with management of these upper respiratory tract infections? So syndromic testing often involve multiplex molecular PCR panels that test for a broad array of pathogens that are associated with a particular syndrome. And that's particularly useful because the syndromes that are associated with respiratory diseases are indistinguishable. And syndromic testing have several advantages over conventional testing. Most of these panels have very easy sample to answer workflow. They have a rapid turnaround time. And in the long term, they can even contribute to cost savings for the lab. In terms of clinical impact of syndromic testing, it increases pathogen detection or rule out, especially for atypical pathogens atypical bacteria such as Mycoplasma pneumoniae, which are not usually part of the differential diagnosis of many physicians. So having Mycoplasma pneumoniae available as one of the targets on the panel allows for detection of these pathogens. For pathogens that have direct specific therapy, for example, flu, RSV, when these pathogens are detected on the panel, you can have direct therapy available for the patients. It decreases hospital admission and length of stay. It decreases duration of antimicrobial use. It decreases exposure to exposure to X-rays. And for hospitals, it's also very useful for implementation of infection control measures as to when to put patients in isolation and so on. So QIAstat-Dx respiratory panel, it's a syndromic panel. It tests for 17 viruses and 3 bacteria using real-time PCR, followed by fluorescence analysis. So most of the samples that were included in this study, I ran almost all of them. And just to briefly talk about the workflow, so the entire time from receiving the specimen to loading the cartridge is about 2 minutes. So here the sample being a nasopharyngeal swab. These cartridges come with a calibrated pipette. So you take 300 microliters of the sample, inoculate it directly onto the cartridge, and the cartridge goes into the instrument. There are no additional equipment required, which makes the workflow easier, decreases chances of contamination, and in about 67 to 68 minutes, you'll have your answer. So for our study, we tested a total of 27 samples. And as I mentioned earlier, the current standard of care at our hospital is the BioFire film array respiratory panel. So all of these 27 samples were previously run on the respiratory panel. So we tested a total of 2 samples that were negatives, and these 2 samples were negative using both panels, so negative on the QIAstat and negative on the BioFire panel. We tested a total of 15 samples that were positive for single targets, and in 15 out of 15 cases, we had concordant results between the BioFire panel and the QIAstat panel. So for single targets, we have a sensitivity of 100% and specificity of 100%. We also tested 10 specimens that were positive for multiple targets. So we had specimens that were positive for 2 targets, 3 targets, and up to 4 targets. So for specimens that were positive for multiple targets, we had concordant results for 8 samples and discordant results for 2 samples. So for sample number 4, the BioFire panel detected influenza A and coronavirus OC43, whereas the QIAstat panel detected the influenza and the coronavirus, and in addition, it detected parainfluenza virus 3 and rhinovirus enterovirus. And for sample number 10, the BioFire panel detected chlamydophila, pneumonia, and rhinovirus enterovirus, whereas the QIAstat panel only detected the chlamydophila pneumonia. So personally, I think one of the biggest advantages of using the QIAstat-Dx panel is the ability to look at amplification plot and to be able to determine CT values for your targets. So the first example here is a sample. This is an actual patient sample that was positive for 3 different targets. So when the result for this sample is released, a physician would get a report that says the sample is positive for 3 different targets. So often in the lab, we get calls from providers saying, hey, what does that mean? So in absence of amplification plot and CT values, we can't really give them any additional information. But having this information available, now I have the ability to go look at these amplification plots and tell the physician that, hey, actually it's influenza that seems to be the more abundant pathogen compared to the other 2 pathogens. So probably it's influenza that's causing the symptoms in the patient. And influenza also happens to be one of the pathogens for which we do have targeted therapy available. The second example here I put up is there's a sample that was positive just for chlamydophila pneumonia. And I put this up here because chlamydophila is a colonizer, so it's also present in respiratory tract of healthy individuals. So the ability to look at CT values might help with differentiating colonizers versus active infections. So in active infection, you'd probably see higher bacterial load as opposed to when it's colonization. So CT values in general and amplification plots can be used to provide more informed interpretation of results to the providers. So now knowing what we know about CT values and amplification plot, we can go back and look at the 2 samples for which we had discordant results. So for example, for sample number 4, the 2 additional targets that was detected by QIAstat panel, you can see have higher CTs than the 2 targets that were detected by the BioFire panel. So at this point, I would venture to guess that it was probably not picked up in the BioFire panel because it was just in a lower quantity. For sample number 10, for example, the only target that was picked up was the chlamydophila pneumonia by the QIAstat panel. And in this case, maybe the rhinovirus was the pathogen that was in lower quantity and was not picked up by the QIAstat panel. But we don't have the ability to look at the CT values using the BioFire panel, so we're unable to make a direct comparison. So in conclusion, so early detection of respiratory pathogens can lead to better disease management and clinical outcome. QIAstat panel is a rapid sample-to-answer platform, detects 17 viral and 3 bacterial pathogens. Its performance is comparable to that of the BioFire respiratory panel, and the availability of CT values and amplification plot might aid providers in making more informed clinical decisions. I want to finish up by acknowledging my attending, Dr. Jennifer Dian-Bard, Rosario Dominguez, who is a technician in the lab and who helped me get this project started, and QIAGEN for providing me the opportunity to speak here, and specifically Brad Peterson, Rosalie Snyder, and Tracy Gambrell. You guys have been amazing to work with, so thank you for that. And I'm happy to take any questions.
Thank you very much, Utsav, for an excellent presentation. What we will do is take a couple of questions from the floor now, but we will have time at the end of the session as well for a more consolidated discussion. So if there are no questions, actually I have a question and rather a comment as well. First of all, I think it was very insightful, your discussion on CT value based on a single example, but however you bring up a key question, which is how do we handle an amount of information that wasn't out there before? And I think the approach you're defining could be the way forward. It might need to be defined in a more systematic way. Again, it's not a company role. It's not QIAGEN role to define that. It's out with the expert in the field, both from the lab and the clinical side. But I think that was very insightful. And what is needed again, to repeat the term of uncharted territory, is an amount of evidence which we did not have before, and how to discriminate the importance among those different types.
Absolutely. So yeah, I don't expect physicians to be able to know what CT values and amplification plots are, but I think as lab directors, we can provide that interpretation for them.
I would agree the clinicians are awful, so yeah, let's leave it there. The question I had was in relation to you obviously as an introductory remark showed the flu peaks and the seasonal influenza peak. I was just wondering whether you see a role and what is the role of syndromic testing in your institution outside of the flu season. I think that's an interesting space to monitor.
So I think that is going to vary depending on the institution. At my institution, we have a big transplant population, and so they're severely immunocompromised. So the bone marrow transfer unit, for example, finds a lot of utility in the respiratory panel. And we have made this panel available to all providers. So yes, our volumes do increase during the winter months, but this test is ordered throughout the year.
Thank you. So if we don't have any question from the floor, there is one there.
Yeah, the reporting of CT values, the test hasn't been approved by the FDA as a quantitative test. And I'm just wondering, it's a leap to informally report those values and not put them on a report with the appropriate validation as to their clinical meaning.
So I wasn't actually saying to report out the CT values. I was saying if the lab director, for example, or the CLSs do get questions, that might help them better answer the questions that the providers ask about, especially when multiple pathogens are detected.
One more question there?
When do you call a CT value as it gets higher, or when do you call it negative?
So I think the assay's CT value cutoff is 40. So, I mean, we wouldn't be able to see anything that's that's greater than 40 on the panel. Yeah.
Great, thank you.
Thank you.
Sorry, there is one last question.
I am Paul Armstrong from Real Diagnostics Lab in Racingtown, Maryland. And I had a question about the accuracy, because healthcare providers, they're interested in viral load for bacteria, colony forming units, and the algorithm to get CT values into those units. How accurate are those units in your system?
So the back.
In our lab, we're doing this as well for urinary tract infections. And the concern is how accurate are these numbers for the healthcare provider?
So the bacteria that are actually part of this panel wouldn't grow in culture. You wouldn't grow Bordetella or Chlamydophila or Mycoplasma. So you'd almost have to, for bacterial, it's mostly the lower respiratory tract specimens, that's more useful to diagnose a bacterial infection of the respiratory tract, right? And as far as I understand, there was good correlation between the viral targets compared to the standard of care methods, and I think Dr. Hansen might shed some more light into that during his talk.
Thank you, Utsav, and thank you. You already introduced the next speaker, so I'll take over from there. Thank you very much.
QIAGEN.
Sample to insight.